Hey there, everyone. My name is Andrew Shedd with Sonoed.
And today we're going to be talking about how to ultrasound the abdominal aorta, and specifically how to assess for a AAA or abdominal aortic aneurysm. Although this is not a pathology that we encounter every day in the emergency department, it is actually one of the leading causes of death in the United States, especially in older patient populations. And it causes thousands of deaths per year. Some sources say 15,000, others say up to 30,000 deaths per year. And this is a time-sensitive diagnosis. Often patients do not survive before they make it to the emergency department, and if they do, their mortality drops by the minute. Why do we elect to perform bedside ultrasound in these patients? Well, the classic teaching that patients who present with abdominal pain and hypotension will have a palpable pulsatile abdominal mass is actually a rather insensitive physical exam finding. And in the critically ill patients, they may not have the time to go to the CT scanner, and also the use of ultrasound spares the ionizing radiation and the IV contrast media. We're going to define an aortic aneurysm as a diameter of the aorta over 3 centimeters. Ultrasounding the aorta is very easy to learn, and this is really a great adjunct to your evaluation of patients in the emergency department who have abdominal, flank, or back pain. And furthermore, in patients who come in with undifferentiated hypotension or syncope, this is a great tool to add to your armament. We must remember, though, that ultrasound, while very sensitive for the aneurysm itself, is insensitive for the leak. Patients who leak into their peritoneum often are catastrophically ill because of the degree of hemorrhage, and they may not survive to the emergency department. The patients in whom we may have time to intervene are those who have retroperitoneal leaks. However, ultrasound is exceedingly insensitive for those leaks. Therefore, we're going to use ultrasound to rule in or rule out the presence of an aneurysm, but not to assess for whether or not it's actually causing the patient's symptoms. Okay, let's talk about AAAs that we find that are asymptomatic. And this will occur frequently when we're evaluating patients in the emergency department and we determine that they have a AAA, but it is unrelated to their symptoms. The natural history of a AAA depends on multiple factors, but principally it's based upon the size of the AAA. You can see here that AAAs under 4 to 5 centimeters have a very low annual risk of rupture. Now, there are other factors that affect the risk of rupture, and that include not only the size, but the rate of expansion, the patient's comorbidities, the size and shape of the aneurysm, and the patient's gender. Now, if we find an asymptomatic AAA, when will it need to be electively intervened on? Well, in general, the cutoff for a AAA that is asymptomatic and not affecting an end organ is 5.5 centimeters, and that's simply a risk-benefit analysis of intervention versus watchful waiting. So to begin performing this ultrasound, we're going to choose a low-frequency probe, either the curvilinear probe or the phased array probe. Recall that these low-frequency probes provide deeper tissue penetration, but at the cost of lower resolution. My preference between these two probes would be the curvilinear probe seen in the bottom image because its larger footprint displaces more bowel gas and is less uncomfortable for the patients. To begin, we're going to start in the mid-epigastric region with our probe in a transverse orientation. Remember that the indicator on the probe will be to the patient's right, which will correspond with the left side of the ultrasound screen. We're going to examine the aorta in its entire length from the most proximal landmarks of the abdominal aorta all the way to the bifurcation. The first landmark that you want to identify on the screen and on the patient in order to confirm that you're looking at the aorta and not another structure is the spine shadow labeled here. The spine shadow is an artifact of the anterior portion of the vertebral body, and the aorta will lie just anterior or just superficial to this structure. This is the most important landmark that you can assess when identifying the aorta because it will help you from misidentifying another structure that could appear similar. So in this image, just anterior to that spine shadow, you'll see the aorta labeled here, and then a little bit more to the patient's right is the IVC. The aorta, being an artery, has several intrinsic characteristics. Arteries have thick walls, a pulsatile nature. They don't have respiratory variation like the IVC when the patient inhales and exhales, and there are multiple identifiable vascular landmarks. In addition, the aorta, as mentioned previously, is just anterior to the spine shadow, although often a little bit to the left. Here you see the IVC circled in red, and this again is a bit more to the patient's right. The IVC, being a venous structure, will have thinner walls, will not have a arterial pulsatile nature to it, and will have a normal respiratory variation as the patient inhales and exhales. It also will be somewhat compressible, and so as you compress the patient's abdomen to visualize the aorta, you may mildly compress the IVC as well. In the proximal region of the abdominal aorta, there are certain identifiable landmarks that we want to look for to confirm what we're seeing. The first vascular landmark that you're going to see coming off the anterior portion of the abdominal aorta is the celiac trunk. Remember that the celiac trunk is a short artery that splits into multiple vessels. Traditionally, it has three branches: the common hepatic artery, the splenic artery, and the left gastric artery. Now, commonly, we only see the hepatic artery and the splenic artery branching off of the celiac trunk, as seen in the color flow image at the top of this screen. But these two arteries give the celiac trunk a characteristic appearance of a seagull's wings, and so this often is affectionately referred to in the ultrasound community as the seagull sign. Look closely at these images and make sure you can identify all of the landmarks. I'm going to label the bottom image to make sure that you're seeing everything accurately. First, we see the spine shadow. Just anterior to that, we see the aorta. And then coming off of that, we have the celiac artery. Let's move on now to the second vascular branch of the aorta that will be just 1 to 2 centimeters inferior to the celiac trunk, and that is the superior mesenteric artery, or SMA. The SMA is a great landmark because it looks like a clock face. It stands out very brightly because it's surrounded on either side by other vascular structures. Here you see again on the bottom image the spine shadow, and just anterior to that is the aorta. And there's your SMA. It looks like a mantle clock. There are two venous structures that surround it again that make it stand out. Just anterior to it is the splenic vein, and just deep or posterior to it is the left renal vein. The SMA is occasionally misidentified as the aorta because it appears so prominent, so make sure that you can identify all the structures on this screen, including the spine shadow, the aorta, and the SMA. Now that you've identified the proximal aorta and its associated landmarks, we want to now assess the remainder of the abdominal aorta. My personal technique for this is to continue pressure applied to the patient's abdomen and follow the aorta as it courses inferiorly. Some authors will advocate for a two-point technique using a fanning method to assess the upper and lower half of the abdominal aorta, but this can lead to falsely increased measurements of the diameter of the aorta when the probe is angled obliquely. Therefore, I prefer to maintain the probe perpendicular to the patient's abdominal wall and assess the aorta throughout its entire course. We're going to evaluate the aorta until it bifurcates into the common iliac arteries. And this is very important because the overwhelming majority of AAAs will occur in this lower half of the aorta. Make sure you can identify the bifurcation in both the still image and the video clip on this screen. Let's look now at some examples. Here's a video of the proximal aorta. Be sure that you can identify all of your landmarks: the spine shadow, the aorta, the IVC, as well as the branches of the aorta. We see here the celiac trunk and now the SMA. Remember, the celiac trunk looks like a seagull's wings and the SMA looks like a mantle clock. Here now is an example of the distal aorta bifurcating into the common iliac arteries. You'll notice that this portion of the aorta appears much more superficial, and that's because the lumbar lordosis of the lumbar spine naturally brings the distal aorta closer to the anterior abdominal wall. In many patients, assessing the abdominal aorta throughout its entire course in a transverse fashion will be challenging because of overlying bowel gas and artifact. For this reason, I teach to assess the aorta in a second axis, the longitudinal axis seen here. You'll notice that the aorta is still anterior to the spine shadow, seen just deep to it. And you'll notice that towards the patient's head, which is the left side of the screen, the aorta dives deep, and towards screen right, which is more distal, it's more superficial. You'll also see those similar proximal landmarks, the celiac artery seen here and the SMA seen here. This creates a really neat appearance if you add color flow, which can help you identify the aorta and its landmarks. If you angle the probe correctly, you can also see the distal aorta in a longitudinal axis. Here's your aorta, and you can see just to the right of that, it bifurcates into the common iliac arteries. This also creates a really cool appearance if you add color flow. Alright, let's put this all together and talk about how we're going to evaluate for a AAA. Recall that a AAA is going to be defined as an aortic diameter over 3 centimeters. To make this measurement, you're going to measure from the outer wall to the outer wall in the anterior-posterior diameter. Now, do make sure that you're assessing the aorta very closely, because you could have a small saccular aneurysm that may jut out just to one side or the other. But in general, because most of these aneurysms are more fusiform, we're going to measure the anterior to posterior diameter of the aorta. You'll need to examine the entire aorta from those proximal landmarks all the way through the bifurcation, and often significant pressure is required to displace the overlying bowel gas and its artifact. I teach our residents that if they're unable to assess the entire aorta in its transverse axis, then they need to include a longitudinal view as well. Here's an example of a AAA. You'll see the aorta lies just anterior to the spine shadow. If we measure from the anterior outer wall through to the posterior outer wall, you'll see that it measures 5.4 centimeters. And while this can be visually estimated using the markers on the side of the screen, I do recommend obtaining and documenting a specific measurement. One of the potential pitfalls of this ultrasound is exemplified in this image. This patient has a very large AAA, but only the central lumen appears anechoic, and there is a large surrounding thrombus. If you just focused on the anechoic lumen and did not appreciate or measure the surrounding thrombus, then you'd probably miss the AAA. This patient's AAA measured almost 8 by 10 centimeters, but if you just focused on the central lumen, then you might have missed the AAA. That's why I emphasize that it's critically important to ensure that you're measuring from the wall to wall of the aorta to ensure that you don't miss the thrombus. I'm going to play for you now a couple video examples of a AAA. In this video, make sure you can identify the spine shadow and the aorta just anterior to it. This aorta is very large. Ensure that you see not only the lumen, but the surrounding thrombus. Here's another large AAA in transverse axis. Again, identify the spine shadow and the aorta. And here's that same AAA in a longitudinal axis. Alright, I got a tough one for you. Here's an ultrasound of the proximal aorta. We know that because not only do we see the spine shadow in the aorta, but we see the SMA. While this aorta is not pathologically enlarged, based upon the markers on the right side of the screen, there is a pathologic finding within the lumen of the aorta. Do you see it? This patient had an acute aortic dissection, and in the lumen of the aorta, you're able to see an intimal flap. Although transthoracic or transabdominal ultrasound is not sensitive for aortic dissection, occasionally you will see intimal flaps as seen here. So let's summarize what we've just talked about. Once you've identified the aorta, you're going to obtain measurements of it from the outer wall to the outer wall, generally in an anterior to posterior diameter. Ensure that you don't just measure the lumen of the aorta and miss a surrounding thrombus. If possible, avoid oblique or angled cuts, as this could falsely exaggerate the true aortic diameter. Also, remember that when you're assessing the aorta in a transverse diameter, it's important to assess not only the AP diameter, but the lateral diameter, as not all aneurysms are fusiform. And probably the most important thing to remember from this lecture is that a small aneurysm does not preclude rupture or leak. In patients who have symptoms consistent with a possible leaking aneurysm, and you find an aortic diameter over 3 centimeters on ultrasound, they need further investigation and further studies to assess for whether or not that aneurysm is leaking. Often, that's going to be a CTA. If the patient is hemodynamically unstable, they may need an immediate surgical consultation just based upon your ultrasound findings alone. All right, well, that concludes today's lecture on evaluating the abdominal aorta for a AAA. If you have any questions or comments, feel free to reach out to me and keep checking back for future content and lectures. Thanks a lot. Bye-bye.